Welcome to Eye Contact, a video news program on issues and controversies in ophthalmology sponsored by EUROTIMES. I'm Sean Henahan. Congenital cataracts account for up to 20% of childhood blindness around the world, with half of these cases being unilateral. Is it better to do cataract surgery as early as possible or wait? What other options are available? We discussed the influence of a large clinical trial that looked at this with Dr. Ken Nischal of the University of Pittsburgh in the US. Welcome.
Thank you.
Let's start by reminding our audience about the design and purpose of the infant aphakia treatment study.
So the IAT study, as it's commonly known, was designed to essentially answer the question whether in a unilateral congenital cataract, implantation with a primary lens implant was better than leaving the child aphakic in terms of visual outcome and surgical complications or complications after the surgery was done. And the 5-year outcomes have just come out last year, and there are numerous amounts of publications about what the group found. The issue when you do a randomized control trial, and this is the first randomized control trial prospectively done for the subject of pediatric cataract surgery, is the methodology. And the methodology was the best they could do given the circumstances that this is not a common disease, and you had to have enough numbers for having the power to answer that question as to whether implantation gave you better vision than no implantation. And so there was quite a large number of patients that they had to enroll. And to do that, they had to basically involve a large number of centers. And so you run into problems when that happens because firstly, you've got to get consensus about how you're going to treat. And that's very difficult. There's a really good example of why that's difficult. There's a paper published recently by Serafina et al., and I was part of that group, where we did the Delphi process for consensus in pediatric cataract surgery management or pediatric cataract management. Now, I don't know if you know what the Delphi process is.
Remind us what that is.
So the Delphi process is used in industry all over the world to try and come to consensus about a pathway or a treatment or decision making. And essentially what happened was that you had approximately 20 pediatric cataract experts from around the world who tried to agree on some of the questions that the IAT study had tried to answer. And the really interesting thing is, in this particular study, because they had people from all over the world and just not the United States, the one point of non-consensus was the minimum age at which you should put an implant in a child. The very question
which is what the study
that
was
IATS
asking.
was trying to answer. And it's interesting that some of the IATS surgeons were in this Delphi process, and within that process it became very clear that while there is some evidence from the IAT study, and we can talk about the pitfalls of the methodology, and in many ways that's irrelevant, while in the IATs the conclusion was that the vision was no better if you put an implant in, but the surgical complication rate was higher if you put an implant in.
At what ages are we talking?
So any child under the age of 1, any infant. So in the actual study, they had to be 7 months or younger. And so any child under the age of 7 months who gets an implant put in, or had an implant put in the IAT study, had vision that was, on average, the same as any child who was left aphakic, but had to go back to surgery or had more complications in terms of anterior membranes behind the implant, and also glaucoma. Now, why that's really interesting is this. The study created a perfect situation. If you were left aphakic, contact lenses were supplied to you, to the parents, free of charge, which of course in the United States doesn't happen. And many insurances will only give you 1 contact lens per year.
Jeez.
The study also didn't compare implantation to wearing an aphakic spectacle. Because when you wear an aphakic spectacle just in one eye, you can imagine how lopsided that becomes for children and how much they hate wearing them. So while the study tried to answer a question, it did it in a way that tried to create a perfect situation. And in reality, that's not what happens. You can't get contact lenses, and often when children wear aphakic correction, because they're thick glasses only in one eye, they tend to become lopsided. And so the reason why the Delphi process couldn't find consensus is that people in India, China, Southeast Asia, Africa, they were saying, if we don't implant, this child's not going to get any visual rehabilitation. So it's an interesting dilemma.
In spite of the downsides.
In spite of the downsides. So here's the other interesting thing. If you look at a study done, in fact, by Trivedi, Wilson, and Vasavada recently about the complication rates in post-infant surgery in children that were operated on in India, they only had a 25% complication rate. Whereas the IATS group had complication rates up to 78%, depending on what the complication was, like anterior membranes and stuff like that. So there's some interesting details that are in the IATS methodology that are worth looking at to try and figure out why there's that difference.
Well, you're in the thick of it. How has this affected your practice?
So it's interesting. In many ways, it hasn't affected my practice because I had very tight criteria as to when I would put an implant in an infant, or when I put an implant in an infant, and when I don't. And the interesting thing is, the commonest cause of unilateral congenital cataract that I see is often due to a condition called persistent hyperplastic primary vitreous, or persistent fetal vasculature. And I often find that in that group, you think the eye is a good size, and you're ready to, you counsel the parents that you would put an implant in if they wanted you to. You give them the pros and cons, and I spend a longer time now because I have to explain the IAT study and why its outcomes differ from other studies, and explain that it's randomized and controlled and others are retrospective, etc. But despite that, if they want me to try and put an implant in that particular category of eye, I often can't put an implant in because it's not safe or stable during the operation. And that comes to a really interesting point. In this particular study, the IAT study, the rate of putting an implant in when a child had been randomized into an implant, I think was over 80%. And when I did an audit of my own rates, when I had decided that I could put an implant in preoperatively, I only actually put an implant in 57%. So even though I had counseled the parents and said, if it's safe, I'll put it in 57% of cases, I didn't do that. In 43% of cases, I didn't put an implant in. And that brings me to another really interesting study published by Mina Matafzi, where with a multiple host of authors, they looked at an independent personalized meta-analysis of published papers about congenital or infant cataract surgery. And this is the first time this has been done in pediatric ophthalmology. What they did was they contacted the authors of the papers that had been published, having worked out which papers could be looked at, and then they contacted them for specific details: age of surgery, what implant was used, where was it placed, how many complications they had, as almost like it was a retrospective analysis, but of papers that had already been published. And what they found was, number one, the complication rate was low. Number two, of membranes, etc. Number two, that if you put an implant in, it was protective to glaucoma. And number three, that this study, which was the largest in terms of numbers, over 500 children, they found that, without a doubt, if you operate on a child before 4 weeks of age, their risk of glaucoma is much higher than if you wait. And the reason I think we found these differences in this study is that all the groups that were invited to take part were people who were doing large numbers of pediatric cataracts and had a lot of experience and would only implant if they felt it was safe.
So are you saying, based on your own analysis of your own work, you might consider actually doing a little more than you have been doing?
So I'm not sure that I would draw that conclusion. I'm saying that I've found so far that my decision-making has served my population well. So there's nothing that the IATS has added that changes my decision-making for the children I look after. So it's not as if every child that walked in who had a unilateral cataract or has bilateral cataracts, congenital ones, gets an implant. That's not the case at all. They all get vetted, they all get evaluated, and even in those where I've said, yes, I think we can put an implant in if you want me to, even in those, 43% don't get an implant. And IATS hasn't changed that. IATS hasn't changed that. What it has done is raised some doubts in people who are considering doing it. And my concern is that there may be children in parts of the world who may end up severely visually disabled because they didn't get an implant when perhaps they should have. And I think that brings me to the last point, which for me is important. There was a study done by the British Isles Congenital Cataract Group, and they looked at their outcome of under 2s getting an implant. And what they found in their last paper, the conclusion was that if you were doing bilateral cataract surgery, the visual outcome was trending to be better if they'd had implants than if they had not, despite increased surgery post-implantation. And that's really important. Because in the developing world, nobody's going to turn up to have a cataract operation on their child when they've got one good eye, because they're not even going to know about it. But the children who have bilateral cataract, they're the ones it's important to visually rehabilitate. And this paper, published in the British Journal of Ophthalmology, is suggesting that their vision is actually better. Now, they put a caveat in. They said, well, maybe you should be careful anyway because of the anesthesia risk in young children. There's a wonderful paper just came out from Toronto Hospital Sick Children showing that when they looked at children who'd had multiple procedures under anesthesia and compared them to the same morbidity group who didn't have as many, there was no delay in development as they got older. So, to put it in that, it's complicated, is the bottom line. But IATS has given us some information that is important. It warns us that if you're not experienced as a cataract surgeon, don't take on putting infant implants in and understand the potential pitfalls. That's very important. It's told us about the fact that if you don't use enough steroid, because the steroid protocol was variable but between centres. And in fact, they did a commentary, the group, in response to some questions that have been raised about the outcomes. And they said in that commentary that even though we had a protocol to start with, it varied. And some people even gave intravenous methylprednisolone, in 1 or 2 cases. So I think what they're telling you is there's going to be inflammation. I wrote a paper showing that if you put intracameral dexamethasone in, you don't get so many anterior membranes. So there are all these little tricks. And I think the basic issue here is you have to look at the population you're dealing with and more importantly, the individual child. If I have a child who comes to me in the United States and they don't have any insurance or they're on Medicaid, the mother's traveling 7 hours to see me, which happens, I've got to be really careful that I don't leave the child aphakic, even if it's just one eye, and put a contact lens in and find the contact lens has been chewed by the dog. They can't afford another contact lens. they're not getting any glasses because she can't get access to glasses because she can't get to the optometrist. And now I get a child who's come back and I've basically blinded that child from deprivation amblyopia. Mm-hmm. So I think it's clear that you have to make that decision based on the circumstances of the child and the eye itself.
Fascinating. Thank you so much.
Okay.
Thank you for joining us. For more information on this and related topics, please visit us at eurotimes.org.